Well, you know me, I talk very quickly, so I'm going to try not to make it a full hour.
Yeah, no, it's just timing.
Oh, yes. Well, 50 minutes.
Perfect.
You don't have to wear this if you don't want to, but it's here if you want it. I'm just going to turn it on. Yeah, this one works really well, as long as you're not a long way away from it, right? Okay. So we've got both. Okay, great.
Well, it looks like we still have 4 minutes.
Yeah, I'm going to do that. Okay. Well, one other thing I'll just point out, there are other sites connected to this, and they're really small, but those are the ones along the bottom, plus 400. So about 8 sites altogether. Okay.
Okay, and this mouse will be okay if I want to use a pointer?
Yeah.
So this is usually the HIV team presents its accounts with thousands.
I think it's the ID one. It's not supposed to be anti-covering film now. It's supposed to be doing it.
It's just like, yeah. Well, some of the people who we recognize are.
But there's also a conflicting center one today.
Oh, is that it?
So I think the CFE is having like a big lunch-hour lecture as well. So I think all the CFE is staying there except for the IDP. Who felt obliged to show up. Hi.
Slum decay. You recognize it?
You could be a CFE person. Oh, Diagnostic. It's a mathematical model.
If you want to start your 2, we'll give you a couple more minutes. I'll just check and see.
Oh, sorry. What was the
Is your usual audience right now?
You're looking at every morning. Every morning I send about 7:30. Look for it. Good morning, everybody. Welcome to Grand Rounds.
Welcome to the distributed sites. As you can see, today's topic is the potential prevention of HIV. Dr. Mark Hall is going to present. Mark?
Thank you. Thank you, everyone. I think this is supposed to be the infectious disease grand rounds, but I hope you'll excuse me for talking about a project that we've been working on for the last year or two, actually a bit longer, in terms of HIV prevention strategies. And I'll be focusing my talk on talking about a fairly new kid on the block in terms of programs that we have available in the province, which is HIV pre-exposure prophylaxis, also commonly called PrEP. Here are my disclosures, and nothing I think in my talk will really be impacted in a sense. And here's what we're going to try and do. I think one of the things that for people that don't do a lot of HIV is I'd just like to set the stage for why we're looking at some of these new tools in our armamentarium for prevention. So talking about why we might be interested in looking at HIV biomedical prevention strategies using HIV medications, not just for treatment, but actually for prevention. For people that are unfamiliar with PrEP, define what we mean by PrEP, and then really look in a broad overview at some of the evidence and the clinical trials that have occurred over the last half a decade or so, steering us to look at the evidence for men of sex with men, which I'll abbreviate as MSM, and also touch briefly on some of the other populations where PrEP has been evaluated. For the clinicians who might be interested in PrEP, particularly either internists who might see complications perhaps arising from medication use, we'll talk about some of the safety and monitoring issues with regards to renal function or hepatitis B infection, and then touch briefly on some of the programmatic work that we've done with our colleagues in Vancouver Coastal Health and BC-CdC to talk about setting the stage for actual program implementation. Hopefully we'll have quite a bit of time for questions if people are interested, so we'll go forward from there. I think for me, when I give any talk about HIV, I really think we have to ground ourselves in the history of the epidemic, particularly now when we're going to be focusing on men of sex with men and HIV prevention. So it was really not that long ago when we started to see cases of Kaposi's sarcoma and PJP or PCP pneumonia, as was called at the time, presenting in young, otherwise healthy MSM. And really, despite 30 or 40 years of other prevention strategies, MSM still remain the focus of the HIV epidemic in a North American context. So here we have data from the Public Health Agency in Canada. It's getting a bit old. Data is back to 2011. But as we can see, if we compare risk exposure categories as reported to public health, MSM still make up the majority of new infections in Canada. So over 50% of new infections occur in MSM. If we look at other risk groups in terms of people who use drugs or inject drugs, there actually has been a marked decline, particularly in British Columbia over the last half decade, as we've scaled up access to harm reduction strategies, needle exchange, and as we've scaled up treatment as prevention within these populations. In British Columbia, we actually have a much more concentrated epidemic, as I mentioned, probably due to the success of our harm reduction programs. So in BC as a whole, if we look at data from the BC-CdC, this is from the STOP report, and we can see as of the end of 2017, MSM make up about 65% of all new diagnoses in the province, and we've really seen a massive decline in new infections in drug-using populations, probably less than 10% if we look at Vancouver data. In Vancouver itself, we have a much more concentrated epidemic. 75% of all our new diagnoses actually occur in MSM. And so it really tells us now we have to look at MSM as a population, a key priority population for other novel prevention strategies if we really want to take steps towards eliminating HIV. If we try and understand why this is the case, I think we have some very, very interesting mathematical modeling data. This paper arises out of England, actually, in the UK. And here, despite what we've done over the last 20 years, scaling up antiretroviral therapy, we still see a very high incidence in MSM. And in their model, one of the key factors that plays a role in perpetuating the epidemic is the fact that transmission occurs in the setting of an acute seroconversion. And in this study, as you can see here, about 82% of all new infections were associated with MSM undergoing primary infection. And so these networks of transmission continue by the time we diagnose somebody and put them on antiretroviral therapy, there's already been forward transmission, really preventing the epidemic from becoming under control. In Australia, we actually have clinical data that supports this concept. Here, they have a cohort study of acute seroconversion cases for about 5 years. And what we can see here is about 30% of individuals were linked to another individual who was undergoing seroconversion at the same time. So really, there's a lot of forward transmission during that first burst of viremia. When people have the highest viral load they're likely to have, they may not yet have symptoms, or if they do have symptoms, these symptoms aren't recognized through clinical screening because they're fairly nonspecific. And so by the time they are diagnosed, forward transmission has occurred. So if we're going to look at prevention, one of the aspects is going to be what tools do we have available to us for people who are actually HIV negative? What can we do for them to lower their risk of infection? In British Columbia, here we have data again from the STOP report looking at stage of infection. And I show you the comparison between MSM and heterosexual populations, really to highlight and contrast these different networks really of transmission. So if we look at the very light blue here, I'm going to use the cursor. This is stage 0. This is acute infection recognized at the time of diagnosis based on the laboratory criteria. Or stage 1, which is somebody who's had a negative HIV test within the last 180 days. So if we look at MSM, we can see the majority of all our new infections actually are part of this transmission cluster. So very early cases have had a negative test or are presenting with acute HIV infection. Very, very few MSM nowadays are being diagnosed with late-stage HIV. We've really mopped up a lot of the outstanding cases due to our scale-up of our treatment programs. Whereas if we look, however, at heterosexual diagnoses, these are predominantly late-stage diagnoses. And this really speaks to the strength of our inpatient testing programs. If we look at data from Vancouver Coastal, probably a third of all our new diagnoses occur from our hospital-based testing programs that are performed when people come into the emergency room or to our medicine programs. And here, this over-selects for people with unrecognized or misdiagnoses in the past. But for our MSM, as you can see, we really do fit these mathematical models in terms of transmission networks. So what are the aspects that we can look at for prevention? Well, we've had many years of looking at individual-level interventions, condom use, behavior change. The province has spent the last decade scaling up antiretroviral therapy as part of treatment as prevention. So I'm not going to spend too much time talking about that, but I think this really derives from the clinical trials HPTN 052, which shows early antiretroviral therapy reduces transmission to partners. This has been reinforced by the partner study that essentially has shown 0 transmission events in people stably controlled on antiretroviral therapy, and reinforced yet again from the Australian data opposite attract, which focused actually on serotransmission or transmission between serodiscordant couples who were MSM. So we have overwhelming data really that shows if we can put people on antiretroviral therapy, the risk of transmission is essentially 0. And this has heralded the onset of the U equals U campaign, a community-based campaign to really get people to look at testing and starting antiretroviral therapy due to its transmission benefits. But what we're going to focus on now is really expanding this concept. So what we've looked at in the STOP report, our main focus has been on this notion of the treatment cascade. And I think I want you to think about the cascade for when we're going to talk about PrEP. Because here, it's a very easy cascade. If you link somebody to care, we can then follow the cascade down. Are they engaged in care? Are they offered antiretroviral therapy? Do they receive antiretroviral therapy? And are they suppressed? It's a fairly standard algorithm that we've been monitoring for many years. But we want to talk now about this blue bubble, biomedical prevention. And so this is something that we've been able to start about 2012 with post-exposure prophylaxis for non-occupational exposure. So we've had a pilot program running since 2012 in the city, looking at offering standard antiretroviral therapy after a consensual high-risk exposure. And now, starting in January, as you've probably all heard, we are able to offer a provincially covered PrEP. So pre-exposure prophylaxis, meaning they get a dual combination therapy of tenofovir and emtricitabine prior to any high-risk exposure actually occurring. And this could be exposure on the basis of sexual exposure or through needle sharing, which would be our other main way of transmitting HIV. What do we use and why did we start down this pathway? Well, we're using a fixed-dose combination tablet of tenofovir and emtricitabine, which has the trade name, which you might come across, of Truvada. These components have a very long intracellular half-life. Very high concentrations can be achieved within the genital and rectal tract. And there's a lot of animal model data suggesting that they could be used for prevention in the context of pre-exposure prophylaxis. And this led to the design of a number of clinical trials, which we'll talk about shortly, that really have shown efficacy in the context of human use. We have very strong clinical trial data in the setting of men have sex with men, a number of clinical trials and open label evaluations. Very conflicting data, however, in the setting of heterosexual use of PrEP. Most of these studies have been run in high-risk or high-endemic countries in Africa, and one trial only in the context of injection drug use, which was performed in Bangkok, where they do not have access to standard harm reduction, and they didn't use full tenofovir emtricitabine, they only used tenofovir. If we look at some of the clinical trial designs, this was actually a very ambitious project run across high endemic countries, so South America, Thailand, South Africa, some cases, participants from the United States. And to participate in this project, you had to be a man or transgender woman having sex with other men, and you had to report condomless anal sex over the last 6 months. And you were randomized at the time, because there was clinical equipoise, to your regular prevention interventions in terms of counseling regarding condoms, testing and treatment for STIs, so sexually transmitted infections, or even post-exposure prophylaxis, or you received Truvada. So you got placebo versus Truvada. In the original clinical outcome, the effect size wasn't that dramatic. It was only about 44%. However, when they did a post-hoc analysis, and they actually restricted their sample to individuals who were actually taking the medications and had detectable drug in their system, there was actually a much higher protection benefit seen, so about 92% risk reduction for the use of PrEP versus placebo. And so then this was further evaluated when they went on to the open label extension. So here in the open label extension, they offered everybody in the clinical trial access to PrEP, and they were recorded periods of when people were on and off their PrEP. And you can see really the power of this medication for HIV prevention. It has a very, very strong dose response curve. And basically, as people start to take the pill on a more regular basis, you see higher and higher levels of protection. In the open label extension arm, in fact, if you were taking more than 4 tablets a week, so 4 to 7 tablets a week, you had 0 HIV infections occurring in that arm. So it was essentially 100% protective. And as you took less and less of your medications, you had less and less protective benefit accruing to you. In PROUD, which was a similar study in England, so here it was a real-world project. People were randomized to immediate PrEP versus deferred PrEP. The Data Safety Monitoring Board of the study stopped the study early due to the high benefit seen in individuals starting PrEP immediately. So there were only 3 cases of HIV if they were doing an intention to treat analysis. But in fact, all 3 seroconverters would not have been protected by PrEP. So the first case had seroconverted at baseline, so probably was seroconverting at the time that they started on PrEP. And the other 2 cases that were assigned to the Truvada arm actually hadn't filled a script for over 3 months. So in that context, again, if you had done a per protocol or on-drug analysis, the protection benefit would have been far higher than the 86% seen in the overall clinical trial. A final study was performed in the context of MSM, and this was performed in Montreal and in France predominantly, and they took a different approach. So again, although the study was designed after the results of iPREX were available, the consensus at that point was that this protocol was different enough that they still could actually offer a placebo intervention. There was a lot of debate when the study protocol was designed, whether or not this was a reasonable approach to take. But what their protocol looked at was a different strategy to PrEP use. So rather than taking PrEP on a daily basis, as was done in iPREX and as was done in PROUD, the IPERGAY study randomized people to what they called on-demand or event-driven PrEP. So here again, you had to have very similar criteria. You had to just report condomless anal sex with partners in the last 6 months. in all these trials, as you can see, due to concerns of tenofovir renal toxicity, for on-label use of tenofovir, you had to have a reasonable GFR with a GFR over 60. But in the study, people were randomized to what they described as event-driven. So this is taken directly from their study protocol. What they did in this situation is advise their participants to take 2 tablets prior to planned sex, a tablet the day later, and 1 48 hours after that. So rather than being on it every single day, you would take medications just around the time that you were planning to have sex, which was thought to be a much easier way to take the medication. And what they found overall is that the outcomes were very, very similar to seen in daily use. So they saw a protection benefit of about 86%. The study was criticized a bit because in the original protocol, there was actually quite a lot of confusion. Only about 50% of people actually were taking their medications as was recommended in terms of the on-demand use. And on average, about 15 to 18 tablets were used per month, which means that people were basically doing what iPREX was doing with their 4 tablets per week type schedule. But this is another set of data that really reinforces the protection benefit of PrEP. If we look at the open label phase, they've now published in the last year an open label phase stage, so everybody was receiving active intervention. The protection benefit was about 97%. So very, very high protection benefit seen for PrEP use if you're using it on a regular or semi-regular basis. If we look then at the effect size and number needed to treat, I think here for internists, this is a very impressive number. If we think about some of the primary prevention or cardiovascular literature, here if we're looking at the number needed to treat on an annual basis to avert a single case of HIV, particularly if you can identify somebody who has belonging to a high incidence population, the number needed to treat is very, very, very small. So PROUD, which was the English study, they found, to their surprise, the background incidence of MSM taking part in the study was about 8%, so 8.9 per 100 person years. So if you can identify such a high incidence population, the number needed to treat was only 13 people per year to avert a single case of HIV, which is highly cost effective if we think about it. The WHO, when they've performed their cost effectiveness analyses, have suggested if you can identify a population where the HIV incidence is over 2 to 3%, this would be a highly cost effective intervention in the era of actually using non-generic medications. We have data now from San Francisco from 2 publications. They've had a real-world program through the Kaiser Permanente managed HMO. And what they've seen there in almost 700 individuals is they've had no seroconversions in individuals using PrEP on a regular basis. So they've had a massive scale-up of their program over the last half decade. PrEP was licensed for use in the United States in 2012. And their only seroconversions have occurred in individuals who've actually stopped taking PrEP for insurance coverage. So financial issues actually, in this context, really were the barrier. So if people were losing their jobs and losing their insurance, they then lost access to PrEP and had 2 episodes of seroconversion, which really, again, speaks to the power of this particular biomedical intervention. So, as I mentioned, there had been a number of other studies in other populations. Here is the data from the African studies, so Partners PrEP and Voice. And you can see, I'll try and move my cursor around, depending which arm of the studies you were looking at, because some of them received Truvada versus just tenofovir by itself, that in fact in some of the arms there was no protection benefit seen, and in fact statistically harm occurred. And so there's been a lot of debate as to why this actually happened. There's very clear adherence-related concerns. If you're not taking the medication, you're not having any effect. But there was a clear lack of buy-in in these studies to looking at biomedical prevention. So it really speaks to the need for community-based partnerships and education if you really want your PrEP programs to be successful. What do you do from a clinical standpoint if you wanted to move somebody onto PrEP? Well, here we recommend at baseline HIV and renal monitoring. We perform urine ACR, really to have a baseline for follow-up to look for tenofovir toxicities. And of course, as we'll talk about for a second, for safety purposes, we want to know their hepatitis serology, particularly hepatitis B, as tenofovir and emtricitabine both are active against hepatitis B. The current guidelines would recommend a prescription for 30 days, follow-up after the first month to re-evaluate their HIV status, and then if everything was stable at that point, you would receive 90 days for ongoing use with monitoring for HIV and renal function every quarter. So what is the obstacles here? Well, one of the main areas of concern and one of the main areas as we start to expand our program is the concern that as we push PrEP into a higher HIV incidence population, individuals could be going through seroconversion at the time they present for PrEP. And so how do we avoid that as a possibility? Because if we put people on tenofovir and emtricitabine and they're actually seroconverting, we may end up with HIV drug resistance. So here I point your attention again to the HIV diagnostics that we have available to us. If you are initially infected, there would be an eclipse phase where we could have no test become positive. Starting around day 10 or 11, we might be able to detect HIV RNA directly, but usually around 14 days or so, we can start to see in blue here, or purple, the HIV P24 antigen, which is detected using our 4th generation HIV assays. And it's only really once we get into the 3rd or 4th week or so that we might see antibodies start to develop that could then be detected by 3rd generation assays. So in British Columbia, our testing capabilities are actually our first rates. We have access to tests that the rest of the country really doesn't use on a regular basis. So standardly, across the province, we now use a 4th generation assay for HIV diagnosis. So if you're testing somebody in St. Paul's, this is the assay that we would use, looking both for P24 antigen as well as antibody. And we have access to RNA testing in the setting of a NAT amplification test. So the BC-CDC has collaborated with the STI clinics servicing high MSM populations. So Vancouver, you would have a pooled NAT test done every time you came for HIV testing in those clinics, allowing us really to move the window period to the left and really minimize the risk of undetected seroconversion. So this really has been a very big strength to the program in the province. What is the concern? As I mentioned, if we miss somebody seroconverting, there is a risk for resistance. And if we look at all 3 of those MSM trials, all of them identified individuals where missed a diagnosis occurred. So in iPREX, people were tested with a regular antibody screen, so 3rd generation assay, but they were actually doing RNA testing retrospectively as well. And so they were able to identify 10 individuals who were actually seroconverting at the time of enrollment in the study. Interestingly, all 5 of the 10 had symptoms that at the time were not thought to be of note, but in retrospect clearly were HIV seroconversion illness, and 2 had leukopenia on their blood work, so a misdiagnosis opportunity. In PROUD, again, there were people that were missed using the 3rd generation assay, using a standard point of care assay, but who were detected using P24 antigen, and this is why our guidelines have moved away from recommending 3rd generation testing if you're looking at PrEP evaluation. So if we look a little bit at the clinical concerns, one of the issues that we know with regards to tenofovir is that there can be proximal tubular defects that occur in the setting of use for HIV treatment. And so we can run into a Fanconi's type picture, a lot of concern with regards to renal function. Dr. Werb is here. He sees a lot of our patients we send to him for tenofovir toxicity. And he might be interested here to see the renal meta-analysis for PrEP. So this is a meta-analysis of all the clinical trials. And luckily, in young, healthy individuals using this medication for prevention, so far there's been only a small signal for minor creatinine changes in the clinical trials themselves. And we now have data from Kaiser Permanente, which, as we talked about earlier, is a large-scale real-world program. And there we actually see some changes in terms of GFR changes over time, but this was predominantly seen in individuals who were entering a PrEP program at over 50 years of age or with pre-existing GFR abnormalities, and they had a fairly steady decline in GFR over time, but nobody actually had to stop the medications because they didn't drop below the accepted cutoff of 60 milligrams per mil. The other safety concern, as I mentioned, was really hepatitis B. Both medications are active against hepatitis B, and so the concern here is if you use PrEP in this context, you would be inadvertently or treating their hepatitis B, which would be fine during the time period that they're using the medications, but if they stop the medications, there can be a flare after you withdraw their hepatitis B therapies. So this was a concern for monitoring purposes and to be sure that people had monitoring for both HIV and for PrEP. So far, there's only been one study, which was the iPREX study that included people with hepatitis B in their clinical program, and only one of the 6 actually had a documented flare, which is reassuring, but still requires monitoring. The other major area, and one of the major concerns with regards to PrEP programming, is it may inadvertently lead to behavior change or risk compensation. So in other words, somebody now is on PrEP, they feel that they're protected against HIV, what they were doing before in terms of condom use or partner selection might change, and so they might actually end up having higher risk or more risky sexual partners than what they would have done not being on PrEP. So this has been a real concern. And what we see, if we look at some of the Australian data, for instance, is that there is definitely a shift to a higher diagnosis rate of other sexually transmitted infections in people starting PrEP. So the incidence, if you look at baseline, was already very high. So about 43% of people had a baseline STI. And this increased to about 119 per 100 person months once they'd been on PrEP for 3 to 12 months. And this is highly debated. The question really is, does this reflect behavior change and change in practices in terms of partners or condom use, or is it really just related to screening? Because now individuals are forced into a regular monitoring program where they're getting testing on a regular basis. So perhaps part of this increase is in fact just due to improved diagnostics and improved diagnostic frequency. And in fact, if we look at some of the US demonstration project data, clearly by increasing screening up to every 3 months, there's about a third of people that are diagnosed at that time with asymptomatic STIs that would have been missed if they were just presenting with symptomatic screening on their own accord. So there clearly is an aspect related to diagnosis as opposed to just behavior change. So what have we looked at if we've looked at PrEP programming in the context of British Columbia? I think we spent some time thinking about this. One of the areas that we've been fortunate to do is that we've been able to look at shifting our paradigm a bit for what this means for individuals coming for testing. So far in British Columbia, for the last 10 years or so, we've really focused on the right side of the cascade, which is if somebody tests positive, we have a suite of interventions that we've been able to offer. We have a stop team. We have early access to antiretroviral therapy. The province has been covering testing and treatment for everybody for HIV purposes. And so we have a big cascade of care that begins once you test positive. And we've looked at what that cascade has looked like in the past. But now with PrEP, we really have to change our thinking. We have to look at this moment of HIV testing not as a moment to ignore somebody who tests negative, but actually to assess their risk and decide would they actually benefit from a prevention intervention. So this is the New York dual cycle cascade, and I really think it's something that's informed our thinking here in the province a bit as well, which is if you test negative, we really have to now look at a cascade that moves back to say what is the population at risk, should they be eligible for PrEP, and how then do we deliver PrEP services. So we have a full shift in our HIV prevention cascade that we have to take into account. We've looked at this as basically mimicking the HIV PrEP cascade. And so the question really is if we take all MSM, obviously not all MSM would be potentially at risk for HIV. What markers do we have that we can identify risk, particularly at a clinical level? In other words, if we saw somebody coming into the clinic or coming for STI testing or presenting to the emergency room, could we have a clear marker to identify that individual as perhaps being eligible for PrEP because we've determined that they're at higher risk than the average population? And if they are at risk for PrEP, where are they in terms of their PrEP awareness? Have they heard about PrEP? What do they perceive their risk to be? And can we then link them into the rest of the PrEP cascade in terms of are they able to see a provider? Can they initiate PrEP? And then can we sustain them on PrEP in the same context as we might sustain somebody on antiretroviral therapy? And so this seems fairly easy, but actually when you start to take it apart, it becomes quite complicated. So one of the risk scores that we started to look at when we started to think about this was using the US CDC risk calculator. This is the HERE MSM score. This is the original one that was published, a 7-item questionnaire that can be readily done in a clinical context. And here the score, if you had a score over 10, had a very high specificity, or sensitivity, I should say, for predicting an incident HIV infection. So if you looked at factors that you could ask very quickly in an STI visit, their age, number of partners, type of sexual practice, and other markers of a higher risk network in terms of use of crystal methamphetamines. These questions, when scored up, would allow you to evaluate somebody's risk. We have collaborated with the Momentum cohort in Vancouver, with Nathan Lachowski and David Moore, who run the cohort. And really, in their cohort, we were able to apply the HERE score and look at its predictive benefit for HIV infection. So in the overall Momentum cohort, in general MSM in Vancouver, the HIV incidence was about 1 per 100 person years. If we applied HERE using the US cutoffs, you can see here a score of 10 doubled your HIV incidence, so it actually was very helpful for prediction. Your score at that point for HIV incidence was 2 per 100 person years at the start of the WHO cost effectiveness scale. And in fact, if you were a young MSM or you had numbers of partners or crystal meth use, your score could go as high as over 25. And there you can see, in that context, we can actually identify a very high incidence MSM subpopulation to people in Vancouver with an HIV incidence over 7%, or 7 per 100 person years. So the HERE score is a very easy clinical tool that we can actually implement at entry to an STI clinic or to another. You could use it in family practice or primary care. As you can see here, we also evaluated STI diagnoses, and this was actually a very helpful marker as well. If we look at STIs, perhaps, there's data from New York as a very good example that you can actually use antecedent STI as another marker for high-risk networks and high risk for transmission. So here there's a study from New York looking at syphilis diagnosis, and they followed almost 3,000 individuals over the course of a decade. And if you presented with infectious syphilis, you had secondary syphilis, you had essentially a 5% seroconversion risk in the year after that diagnosis. And if you had syphilis and another bacterial STI, your HIV incidence was 7.89% per year. So a very high incidence criteria that, again, is a very easy marker for the healthcare system, because once you have an STI diagnosis, there are public health interventions that would link you to treatment for your STI. And so the question would be, can we layer on a referral to PrEP on top of the standard STI interventions that we might be able to offer? We went on to evaluate this, again, not only in Momentum, but we collaborated with the BCCDC STI clinic data, and with our colleagues there, we were able to look at the prediction benefit of targeting PrEP to a high incidence population. And we can see, if we look at syphilis diagnosis in British Columbia, rectal gonorrhea, or in our cohort here at St. Paul's, use of post-exposure prophylaxis as a prevention strategy, these are all able to point to very high incidence populations where we can clearly meet cost-effectiveness criteria and fall well within the entry criteria seen in the clinical trials that we talked about earlier. In fact, in British Columbia, if you have a dual diagnosis of both rectal gonorrhea and syphilis, your HIV incidence was 17 per 100 person years during the follow-up period, which is a very, very markedly elevated risk group, and really points to the need to link individuals with these diagnoses to a PrEP program. So I think we've always thought about STIs as just something minor that we should offer treatment for, but clearly they are a good indicator of high-risk sexual networks and HIV risk transmission. One of the other pieces of work that we've done looking at risk prediction is we've looked at Momentum and asked individuals, do they classify themselves as being at high risk or low risk for HIV? We presented this data for CAR, and it's currently actually about to be submitted for publication. We looked at the three categories that we've just talked about: HIV prediction based on a HERE score, prior rectal STI, or a HERE score over 25. And we can see here, just to remind you, the HIV incidence in the Momentum cohort per 100 person years, 2 per 100 person years, 4.84 per 100 person years, and for MSM over 20, with a HERE score over 25, it was 7 per 100 person years, so 7%. So a very elevated incidence. But we asked those individuals who fell into those categories, do you think of yourself as being low risk or high risk for HIV? And you can see there's a big disconnect actually in self-perceived risk. So if we look at a HERE score over 10, 88% of people thought of themselves as being at low risk for HIV infection, even though we had HIV objectively, the incidence is doubled from 1 to 2%. If you presented with a rectal STI, there was less people that misclassified themselves, but still 80% of individuals whose HIV incidence is now almost 5-fold higher than the general MSM population in Momentum still misclassified themselves as being at low risk for HIV. And finally, if we look at HERE score over 25, we can still see 2/3 of individuals consider themselves to be low risk for HIV, although their HIV incidence is actually 7-fold higher than other MSM in the cohort. And so this has told us we really can't rely on people walking into your clinic saying, oh, I need PrEP. We really have to look at how the healthcare system can identify people and actually start to provide counseling and start to provide awareness so we can actually link these people who are misappreciating their risk into an HIV prevention program. Part of this has been improving community awareness. The Health Initiative for Men campaign has been offering for many years very up-to-date and very clinically accurate information. This is a screenshot from their website, which is called Get Prepped. I always felt it needed another P, but that's okay. And so they have been offering community events over the course of the last 4 or 5 years, and we've done a number of what we call PrEP schools, where we've had community forums in the evenings. We've answered questions about PrEP, provided PrEP education and PrEP learning, and we've expanded this with some of our community partners to outside of Vancouver, and I'll show you why in a second. What we've seen as a result of the enhanced community awareness campaigns is actually a massive upswing in PrEP awareness in MSM. So this paper has just been published by the Momentum Group, and we looked in this cohort at whether people had actually heard of PrEP. And you can see back in 2012, when PrEP was just approved in the United States, less than 20% of MSM in Vancouver had ever heard of PrEP. And yet, when we finished some of the community events, or HIM has run their community events over the last half a decade, by 2016-17, about 80% of MSM actually had become PrEP aware. So we've really seen a massive upscale in terms of people hearing about PrEP, and we hope now this will translate into actual seeking out PrEP and PrEP interventions. One of the other projects that we've done and we'll be presenting a work at later this year at CAR when it's here in Vancouver in 2018 is the Sex Now survey. It's a large online survey that gets offered across the country. We were able to look at PrEP awareness in 7,000 MSM. And what we can see is British Columbia numerically has more PrEP awareness than all other provinces, including Quebec, actually, which has had a provincial program for a number of years. But one of the areas of concern in terms of equity to health access is really there's a very big discordance between what people in urban areas and people in suburban or more rural settings are aware of in terms of PrEP. So we've done very good work in terms of improving awareness in our urban centers. And now, over the last year or so, we've collaborated with groups in Prince George and Kelowna and Victoria to start to try and improve some of the PrEP awareness outside of our main urban centers. So I think definitely there are some health access and equity issues that still have to be addressed. The other major area, if we're going to look at the PrEP cascade, is not so much focusing really on the individual themselves, but really what is the availability through a healthcare system in terms of looking at PrEP availability for PrEP awareness for providers. So if somebody comes in, would they actually find a doctor that would be aware of PrEP, be knowledgeable enough to provide it to them, and then be comfortable to monitor them while they're on therapy? We have some data, which I'm not going to show at this point because we're going to present it in the next few weeks at the CAR conference, that if we look at Momentum, actually very few individuals have a family doctor and are actually out to their family doctors. So we have to start thinking about other access points if we are going to have healthcare providers become aware of PrEP. This is data from the United States by Andy Petrel from the University of Wisconsin. They have a very interesting survey they've been doing repetitively over a number of years. They've asked U.S. primary care providers what do they know about PrEP and what have they done in terms of PrEP prescriptions. So as you would recall, PrEP has been available in the United States since 2012, and despite that now, this data goes up to I think about 2015 or 16. Very, very few primary care providers actually have been prescribing PrEP. And so there is still a huge knowledge gap issue if we're going to look at making access available or equitable is to improve knowledge amongst healthcare providers as well. We asked a small group of GPs taking part at the St. Paul's conference last year what they know about PrEP, and we'll be presenting this data a little bit later on again at CAR. And you can see we actually had a very interesting split in terms of what people reported as how they rated their own knowledge for PrEP. So we felt this is a group coming to CME education, probably amongst the most engaged and interested potentially participants, and only about 30% of people rated their knowledge as being good or very good for PrEP prescribing, and we broke it down into looking at all the aspects in terms of counseling for PrEP or monitoring and awareness. And so it really tells us if we really want to scale up PrEP, part of the work that we have to do is trying to improve access to resources or access to CME education events and CME activities for our primary care providers. We've tried to focus on this a bit by standardizing what we would consider interventions. We have worked with a group across the country over the last 2 years, developing Canadian guidelines for HIV pre-exposure prophylaxis and non-occupational post-exposure prophylaxis to really try and standardize across our country what people can have access to in terms of recommended regimens and recommended follow-up. And in British Columbia as well, we've had guidelines over the last 4 or 5 years, which have most recently been updated in October this year, really to recommend evidence-based interventions based on some of the risk group criteria that we've just talked about, and also to try and standardize the monitoring that people might have to undergo, really to try and improve and make things simpler for GPs taking on PrEP as part of their practice. If we look then at access points, what we've really focused on is saying we have opportunities now with our sexual health clinics and with our public health colleagues, because people presenting with STIs or presenting for screening might be the most ideal candidates for HIV PrEP interventions. And so we've been able to work with our colleagues through 2 implementation grants, really to start to set the stage for actual practical implementation in the city at this point in time, anticipating that we'd eventually have a public program. So we have held over the last few years a PrEP working group. We've had monthly meetings engaging with our local stakeholders and community stakeholders, and really have spent the last 2 years sort of looking at where people access prevention services at the moment. Where do they come into contact with the health system? How can we use that access point to educate or steer them into a PrEP program? What do people in the community know about PrEP, which we've already sort of looked at in terms of data, and really evaluate what people were doing through some of the buyers clubs or online access strategies that people were using prior to obtaining provincial PrEP. So we've had a number of focus groups and surveys and really tried to shift now our healthcare resources. One of the things that's been very challenging is our STI clinics really up until now have looked at episodic care. So people come in, they'll have an episode where they have STI testing, and that's it. They wouldn't be seen for long-term care. So how do you shift a model where people come for episodic care now to a model where we try and integrate long-term longitudinal care into the clinic? It's actually been quite a lot of work for BCCDC and VCH to start to shift their models a bit. But starting in 2017, we were able to start some pilot projects at the Health Initiative for Men Clinic and now the Butte Street Clinic operated by the BCCDC, and have an integrated physician nursing model where people come in for an STI assessment. Even if they weren't really thinking about it, they get offered a HERE score as part of their baseline assessment. If they have a HERE score over 10, or if they're diagnosed with an STI, then they're considered eligible for PrEP, and they're offered referral into our PrEP community program, where they are seen by a physician, they're assessed, and then we integrate physician and nursing follow-up to try and increase the access points for individuals to get actually a service provider. Luckily, we have, through the Center for Excellence and the work of Dr. Montana, been able to lobby and make a case at the provincial level for access to PrEP. And as of January, the province is actually covering PrEP for all eligible people, which has been a tremendous a step forward. It puts us at the forefront of the country, in fact, in terms of PrEP access. We're the first province to have unrestricted access for eligible individuals, and it really speaks to, I think, to the province's commitment to HIV elimination. We have eligibility criteria based on our Canadian and provincial guidelines, really trying to use evidence-based strategies to get people moving forward into a PrEP program. So we have MSM criteria based on HERE score or prior STI or prior post-exposure prophylaxis, people who have partners where they're not fully suppressed on antiretroviral therapy, or PrEP available to individuals who would use drug paraphernalia or use drugs with a partner, again, who would not be fully suppressed on antiretroviral therapy. So we've had an up and running PrEP program through the center. I would acknowledge the work of Janine Toy, our program lead at the center, to really have this program up and running. And it's been actually very successful over the last few months. Since we started in January, we now, I think at the end of March, and Linda might, Janina's here, she might correct me, we have, I think, about just over 1,200 people actually have accessed provincial PrEP, which is a huge upswing over the course of the last 3 months. And I would say probably a third of those actually are probably accessing through our STI clinics at Buttes and HIM. So it really speaks to the work that our community partners have undertaken. I think we have to be very encouraged by this. Here are news reports from cities that have scaled up PrEP over the last 2 years. If we look at London, they've had a very concentrated PrEP program at some of their MSM STI clinics. And when they compared new diagnosis rates seen traditionally in those clinics versus clinics not offering PrEP, there was a massive reduction in new diagnoses, so 32% reduction in clinics providing PrEP, so 32% drop in new diagnosis in clinics where PrEP was made available, compared to only 8% in clinics where they were just focusing on scaling up antiretroviral therapy. And similarly now from Australia, just reported from their PrEP demonstration project, again, about a 30 to 40% drop-off in new HIV diagnoses, particularly the ones that we're seeing in Vancouver, acute or recent infections. So it's very clear, if we can target PrEP and we can scale it up, we have examples from around the world that suggest this may have a very high protective benefit for HIV elimination. And some of our mathematical modelers, Viviane Lima and Ignacio Rosada, have looked at various models of incorporating PrEP into our standard HIV prevention strategies where we focused on treatment as prevention. And we can see here, if we're able to scale up our treatment as prevention as we're already doing, and yet add on targeted PrEP, looking at 5,000 high-risk MSM, we're already 1,200 out of those 5,000 MSM hopefully on the way. We can see over the next few years, we would anticipate a very significant drop-off in terms of new HIV diagnoses in the province. So it's a very exciting time to be looking at HIV and HIV prevention and incorporating combination prevention into our care programs. I think we're on time for some questions. I will conclude at this point and say that overall, we've had tremendous success over the last decade scaling up HIV treatment as prevention. But despite this, we still have a burden of disease amongst men who have sex with men. The transmission networks that we see there really allow ongoing transmission prior to us intervening with HIV treatment. And that population actually would be a key population where we want to scale up some of these novel aspects in terms of biomedical prevention. And so what we're hoping to do really over the next year or so is continue to work with our community partners, scale up access through our STI clinics, scale up access through our public health notification programs, and really start to see, hopefully in the next year or two, decreases in our own HIV diagnosis rates as have been seen elsewhere in the world. I'd like to acknowledge some of my colleagues, Dr. David Hall at Vancouver Coastal Health, Misty Afshan-Natu, the program leads for the Health Initiative Men Clinic, Nathan Lachowski from Momentum Study, and Georgie Jollymore, who's done a lot of work in that community. So thank you very much, and I'm happy to take some questions.
Any questions for Dr. Hull? Comments? Yes. Could you use your...
Here, mine works.
So just talk loud.
Yeah.
This is more so a comment. So a very close friend of mine who's high risk, is known about PrEP. His biggest barrier and he lives in Vancouver, his biggest barrier he's experienced is exactly what you pointed out, is actually getting it prescribed. So he actually regularly goes to the HIM clinic, and they provided him resources to give to his family physician. And the family physician hadn't heard about PrEP, but, was engaged. Like, he's open with his physician. She said she would look into it. And then, unfortunately, after saying initially that she would prescribe it, he, went through baseline testing, then came back and said she was uncomfortable prescribing it because she was afraid of missing something on follow-up and essentially just didn't want to be responsible for it. So he's been frustrated by the situation because he's felt like he's going back and forth about actually getting it. So now he's going back to the HIM clinic. But he's saying now, again, I think the other barriers now,
The wait.
you can't make, exactly, he has to wait again. You can no longer make appointments. So, you know, he works full time, so he just has to like go to the clinic and hope he can get an appointment. So just a lot of these like logistical things.
Yeah, this is what we've been trying to work on and what we've anticipated. We knew if we left it just to the GP side of it, it's a lot to ask for GPs. And I think, unfortunately, for your friend is lucky as a GP, but a lot of young, healthy MSM do not have primary care providers. I think it's true even for people that are not young anymore. They don't have GPs. But one of the things that we found is with him, the amount of space that we have has actually become saturated so quickly that where initially we were taking everybody as walk-ins, you know, now there's, I think, a 2-month waiting list actually to see a provider for PrEP. So this is our biggest concern, and a lot of the work that the center has done with Sylvie Guillemey and Janine is we've tried to host more CME education events for family doctors, because it's really a very simple thing once you get started on it. It's not that complicated. It's a question of doing an HIV test every 3 months. You're not going to miss that many things at this point. So we've had a provincial webinar to promote education for primary care physician. David Hall from VCH and Dr. Guillemey, who's our education lead, are working with UBC to see what CME activities can we do to broaden interventions for GPs. But I think this is going to be the issue, which is there was formerly a financial aspect. Nobody could afford the medication. Now that we have a provincial program, the question really is how do we support access to care? And what I've said before is my big concern is really there's also a health inequity across the province, which is it requires a lot for people in small towns where you for sure may not be out to your healthcare provider, who you may know in a more social setting, to come up to them and say, oh, now I need to get onto PrEP. I need to tell you all this detailed information about my sex life and access it. And we worry that could be a barrier outside of Vancouver as well. And in Vancouver, we're lucky we have partners where we do actually have STI programs. If you're in the interior or if you're up north, there actually are no STI clinics that we could use as an access point. They have a lot of drop-in evenings, and a lot of the STI clinics that have been closed down. So we have quite a lot of work ahead of us in terms of community partnerships and improving access to equitable access. And I think what you've said is really our big concern, and a lot of the work that we've done is to try and avoid that. So it sounds like we still have work to do.
Yes, Keith.
You talked about networks of transmission, and I imagine that the network structure would follow a power law, would be fractal, kind of like Facebook or the internet. So some folks would have many connections.
Yes.
A fraction would have many fewer, and truthfully, most folks would have not that many connections. Beyond the scoring system that you have, do you have any other ideas how you might target the super transmitter folks? And the second question is, how about time? Like, is Thursday through Saturday night the high transmission time, middle of the week lower transmission?
I don't know if we know really about transmission time, to answer your second question first, because really we only can identify somebody at the time that they diagnosed. I think transmission times have shifted if we look at what people are accessing for how they meet their sexual partners. Before, if we went back maybe a decade, it would have been a weekend type thing where you had Friday, Saturday off to the bar. Now with access to all the online dating apps, Grindr, I think there's no clear rhyme or reason to how people meet their partners. We have had a lot of thought about how we might target these networks in a bit more detail. So one of the pilots that we actually ran with public health prior to having a provincial program, and it still is an access route that we can identify, is we know if we look at what public health does with the virology lab is if they see a new diagnosis, it actually goes through phylogenetic analysis to determine if it's part of a cluster of ongoing transmission or not. And so we were working with public health to offer partners of a new diagnosis to say, oh, you've tested positive, your virus tells us you might be part of an expanding cluster. Would you be interested in referring your sexual partners in for PrEP. So we have what we call a targeted public health access program for PrEP that's available to us to try and target the networks a little bit more effectively. What we found so far in our pilot is actually there wasn't a lot of buy-in, mostly because people either couldn't identify their partners because they were anonymous, or if they did identify their partners still had this disconnect where they didn't consider themselves to be at risk. So even if we said to them, oh, your sexual partner is just seroconverted, here's free PrEP, would you be interested in taking it? Our uptake was, I think, 60%. So 40% of people who had this event and were offered free PrEP still said, oh, I don't think this is something that I'm interested in. So I think, again, it points to the need to really improve some of our community education pathways to really normalize PrEP as an intervention in this context. But yeah, we've really thought about the targeting aspects quite a lot. The problem is we're always lagging because we can only identify those transmission networks once somebody has something that we can follow up through public health, through an STI or a new diagnosis.
Yes.
Ignacio.
Thanks, Dr. Prophet.
Thank you for your data.
Is there anything being done to couple the HIV tests with people on PrEP with also STI tests for syphilis or gonorrhea?
So everybody who is followed through the main clinics or is following our guidelines would be having quarterly monitoring. So if you start on PrEP, if I'm understanding you correctly, are we doing STI monitoring? So yes, you get baseline STI testing, and every time you come in for a quarterly visit, you get a full panel of STI testing at the same time. We're trying to do things in reverse a little bit more, again, as part of the targeting aspect, which is to say, if people have a notifiable STI diagnosis, can we use that moment where we're offering them treatment for their syphilis or gonorrhea to provide further education and further entry points into a PrEP system? So that's some of the work that we're doing with BCCDC and Vancouver Coastal to try and change some of their partner notification programs to go in the other direction. But yes, for PrEP, we're having a full-scale STI screening program on every quarterly basis.
Any other final comments or questions? If not,
next. Somebody's trying to...
Sure.
That's from pediatric side. Do you have to be 18 to be eligible for PrEP?
No. So there definitely are high-risk younger individuals accessing the PrEP program. So I think our youngest person who is presented for care at the HIM clinic has actually been 16 as far as I'm aware. And he's essentially an emancipated minor. But had started PrEP prior to the public health program through his parents' healthcare program. So I thought that was very enlightened. His parents put him onto PrEP. So I was like, okay, there you go. Great. Well, thank you very much.
Your call will be disconnected.